Okay, thanks, Dr. Paul, for coming today. Basically, we're here to talk about, policy making and bringing the field forward in obesity and steatotic liver disease. I was just wondering whether you could just quickly introduce yourself for the audience.
Yeah, thanks very much for having me. My name is Paul Brennan. I'm a clinical lecturer at the University of Dundee and an honorary research fellow at the University of Edinburgh.
Okay. So, I'm looking at a study that's been published in Gut, looking at beyond a liver gut focus and the evolution of gastroenterology and hepatology in the challenge and in challenging the obesity and steatotic liver disease paradigm. I'm just wondering whether you could share some insights into how this thing was being crafted.
Yeah, sure. So it really came about from the original paper published in Gut by Emad Olamar and Michael Camilleri, who looked at kind of 10 facets why a gastroenterologist should be involved and interested in obesity and how we can play a critical role in addressing both the direct consequences and the sequelae of obesity in our general practice, split between luminal gastroenterology and hepatology. And really, a lot of what we were doing, as you say, the likes of Jeffrey Lazarus and some of the other people progressing the public health sphere and looking at expanding the field of practice within of the obesity sphere and the wider steatotic liver disease sphere, and felt that we could advance some of their arguments and propose other interesting areas which aligned with what they proposed, but also looking at some of the more public health directed policies, areas in which we thought there may be challenges in addressing obesity and addiction medicine in traditional gastroenterology and hepatological training programs and fellowships, and how they could be expanded right through to the undergraduate level as well, particularly with the nomenclature change, that actually this probably represents a kind of a seminal time that we can influence the field going forwards in terms of education, awareness, and training to equip the next generation of clinicians and researchers to address the real multimorbidity that's associated with metabolic disease, and that encapsulates steatotic liver disease, obviously, as an entity.
Okay. And in your experience as a trainee, has any like emphasis in place in the field of obesity, as a gastroenterologist itself?
Yeah, so we're quite lucky in some of our training. We do have joint clinics where we have metabolic and cardiovascular risk clinics where we would have joint input from metabolic medicine specialists, clinical biochemists, gastroenterologists, and hepatologists, as well as input from some of our bariatric surgical colleagues and dietitians and psychologists. But generally, in the whole in the UK, they're pretty rare that such a kind of an MDT exists. So really, we felt that equipping people earlier on with at least some educational awareness around the tools that they can bring to their own practice, even in isolation, could be beneficial in tackling some of the multimorbidity. Because again, we recognize, particularly in MASLD, that the majority of patients will succumb to cardiovascular disease and solid organ malignancy. So again, these are critical points that we can address as clinicians, including that of our general internal medicine training, which is probably a unique aspect of the UK training scheme, which we do recognize, but probably highlights for those other specialties to have some additional training programs incorporated into those other models.
Okay, cool. Do you mind sharing more about the multidisciplinary program that you guys have? I think that's very unique. I've never heard it before. So,
Yeah, so there's a couple of centres around the UK that kind of centred on a what would have been a NAFLD model, but incorporates specialisms from, as we said, bariatric surgery, which sometimes exist within what we call tiered weight management services, and they can be a separate entity, but we've tried to incorporate them within our MASLD or SLD pathway. We have dedicated dietitians, and we also have an advanced egg patient program that they can enroll in a hypocalorific diet, similar to that for early type 2 diabetes. And again, tends to be coordinated by psychologists and dietitian services. And we've integrated them into our natural flow pathway. Um, and patients often can self-refer from primary care if they've been identified as having high-risk features, and they can undergo an online program to begin with, which incorporates some psychological counseling, food awareness and education, and then structured interviews with a psychologist and dietitian. Within our NAFLD or MASLD clinic, we then have access to our specialist nurses, direct access to our surgeons as necessary, as well as we've got a clinical biochemist who also specializes in high risk lipid disorders. So again, feeding in patients who may have polygenic cardiovascular risk or polygenic familial hypercholesterolemias, who may need aggressive statin therapy or PCSK9 inhibitors. And they can come and see us in a one-stop shop, essentially, to try and identify or modulate most of their risk factors. We usually have a diabetology specialist as well, but again, we have pathways where we can prescribe drugs that would usually be for type 2 diabetes, but in individuals who may have MASLD, we again would have relative free reign to prescribe GLP-1 receptor agonists, pioglitazone, as well as then if for more difficult to treat or people needing insulin or escalation with multiple regimes, we then just refer to our diabetes colleagues.
Okay, okay, wow, that's very interesting. I've never heard of that concept before, being deployed. So I think that's the first that I've heard. With over like 60 to 70% of people, I've done a study previously and published in Lancet Gastro, looking at the rate of obesity and overweight patients with fatty liver, and we have over like 60 to 70% of patients with that disease. In your experience, in this metabolic clinic, has GLP-1 greatly reduced risk of like all weight as well as fatty liver disease?
Yeah, so we in the UK we've got quite a challenge accessing our GLP-1s in the last year, mainly just due to the worldwide shortage of semaglutide. But generally, for those patients that we previously had identified as existing as F3 plus, we do notice significant improvements in the realms of about 10 to 12% weight loss, which seems to correlate with overall reduction in certainly in FibroScan. We tend to not repeat biopsies or minimally repeat biopsies. So yeah, I certainly think it's a significant or it has the potential to significantly alter the natural history of what we're seeing in our clinics. And again, we've got some very aggressive cardiology colleagues who, again, with the results from the SELECT trial, are very keen to embrace and to utilize it as early as possible.
Okay, okay. So yeah, the assessment for fatty liver per se is using like 2-point FibroScans or
Yeah,
how?
so our population in Dundee is quite unique because we've developed the intelligent liver function testing. So all individuals in Dundee in Scotland, if a primary care physician is requesting liver function tests, they automatically will trigger a reflex fibrosis assessment in people
Wow.
who have abnormal. It's usually triggered on ALT, but can be triggered on ALK Phos gamma GT. And it requires the GP or primary care physician to input some basic metabolic parameters, so BMI and the units of alcohol they drink. And the lab system actually automatically then reflexes and will perform hepatitis assessment if there's significantly raised transaminases. It'll undertake antibody screening again in patients who trigger based on our set parameters. And it'll reflex to FIB4 and NAFL fibrosis score. And then those patients who have an indeterminate or elevated score based on age-adjusted profiles will automatically get an ELF added on. And then again, if there's synchronous kind of positivity between those, they'd get referred to clinic where we'd undertake an initial FibroScan. Or if they were going through a slightly different pathway, they'd get an ultrasound scan with shear wave elastography, and then they'd come to see us in clinic.
Wow, you have a very good referral pathway. I think one of the best I've heard, from primary care to specialist care. And I think this is
Yeah,
probably one of the best that I've heard, that everything is done on the background, it's automatically done.
Yeah, so it involves a very specific. The algorithm is quite easy to write. It's mainly the infrastructure around the laboratory and the laboratory information management system. And so not all places have the caliber of equipment that can endorse it, but it's been recently adopted by NHS England, the Association of Clinical Biochemists, a version of it. And we're about to roll it out to all of Scotland as well in some form. So again, it's basically about we recognise that reducing burden on GPs to identify liver disease should sees increasing referral to us in clinic, but are the patients that we want to see and can offer the most appropriate interventions based on their stratified risk. And that plays into some of the other things that we're doing in terms of identifying specific pathways for patients with diabetes as well, who undergo enhanced stratification and risk assessment depending on cardiovascular, renal, diabetes or liver risk. So again, we're developing these new automated systems to deliver tangible change for patients in primary care so that because things are moving so rapidly, we can take the onus off GPs having to keep up to date by just automating and standardizing our practice.
Wow, okay. This is probably one of the best referral pathway that I've heard. Everything is done on a back end whereby it doesn't require like any additional like input per se. It's been done like automatically by the system itself. So I think that really helps the GPs out, and so they can concentrate on just looking at patients and letting the system run its toll on the adding on tests as necessary for our patients. In the field of both obesity and steatotic liver disease, or MASLD for that matter, um, how do you think we can move forward from here, like from where we are now?
Yeah, so I think to our mind, there's probably multiple areas that need to happen. I don't think there's a singular intervention that's going to alter the natural history, and I think we have to be mindful of that and how we as clinicians devise our services. So I think with the work with Jeffrey Lazarus and that, we recognize that there's the public health approaches that are the foundation because they're the only sustainable way of altering the increased burden and prevalence. So again, it's having horizon scanning long-term visions that some of these policies will take 20, 30 years to mature and to actually infer meaningful change. So things that we talk about are essential nutrition, reduction in social deprivation, green spaces for exercises, social prescribing, where again we can demedicalize the whole idea around obesity and metabolic health as much as we can, while recognizing that there's a role for medications and pharmacotherapies. I think we also recognize that we should be able to find high risk populations where we traditionally rely on people coming and going to primary care or secondary care and engaging and having a blood test, and you can have the best biomarkers in the world. But if patients don't declare themselves until they have advanced chronic liver disease or decompensated disease, then that's probably already too late. So again, we're looking at ways that we can find high risk persons in places of high prevalence. So again, recognizing they exist in people in lower socioeconomic groups, people who consume too much alcohol and have a metabolic risk. So in this METALD group and going out and finding them. So can we go to the patient and do, point of care, lateral flow type chip on a stick, AST, ALT ratios, simplistic things. Can we enhance understanding and awareness amongst patients and going out and doing things like the British Liver Trust, where we engage a Love Your Liver week and go out and offer free fiber scans? Can we sit outside pubs and football matches? And again, really just raising awareness of the profile of liver disease and recognizing that it's generally asymptomatic until very advanced. So I think they're important. And then from a clinical side, we need to recognize the fact that this is a multi-system disease and changing our mindsets from being siloed into being hepatologists or gastroenterologists or renal physicians, and recognizing that each individual has a specific specialism that they want to particularly infer a treatment strategy, but recognizing again that there's polypharmacy issues, there's issues with iatrogenic harms from certain medications when not considered in the context of multi-organ dysfunction. And again, having broad oversight and more generalist approach to these things is probably really important. So again, enhancing training pathways for all of these people, and we try to suggest that whether you're coming to a liver clinic or a lipid clinic or a cardiovascular clinic, the message should be the same. We should be conferring the benefits of weight loss, exercise, Mediterranean diets, hypercalorific diets or time-restricted eating in certain populations. And again, trying to create awareness, particularly in primary care, that actually, fatty liver or MASLD, SLD, these are not benign bystander conditions. They're a reflection of overall metabolic dysfunction and overall poor metabolic health. While recognizing that the majority will succumb to cardiovascular disease. That doesn't mean that just because they don't have advanced fibrosis that we shouldn't be interested in their overall health.
Right, right. Thanks for sharing about that. You know, I'm just thinking to myself about how you mentioned that the test automatically adds in ELFs for patients in primary care. Is that right?
Yeah, yeah,
Okay, but then when they get their clinic, they still do a fibro scan.
yeah.
Oh,
So we use that as so essentially it's this idea of sequential testing to kind of increase your positive predictive value by the time they get a fibro scan. Um, is the kind of theory behind it. So again, so they have to trigger on one of the FIB4 or NAFL fibrosis, then their ELF. If the ELF is less than 9.8, they can go back and have a repeat non-invasive biochemical test within 3 years, as per EASL best practice. If it's greater than 9.8, which is lower than some of the recommended thresholds, then they would come and also get a fibroscan or shear wave elastography and a clinic appointment. And yeah, so NICE is interesting. So the National Institute of Clinical Excellence in the UK actually advocated a cutoff of 10.51. And we recognize that the American AGA has suggested a cutoff of 7.7. So again, there is some variance amongst that, but we've done some reasonable validation, and we think 9.8 is probably a reasonable threshold in terms of sensitivity and specificity, and not overburdening clinics and not having too many false positives, particularly as we know that it seems to perform poorly in patients over 75,
right.
a bit similar to FIB4 and most of the other biochemical markers, I suppose, that we recognize the age limitation.
Right, right, right. Okay, cool. So on the other side of the coin, I wanted to ask regarding the fact that how sustainable are like non-pharmacological. Just wondering, like how sustainable are the non-pharmacological methods of weight loss? Because in my experience, they generally do they do come back after a while. And in your experience, how has it been in this multidisciplinary team care?
Yeah, so similar to most, I think a very small subset, probably 5 to 10%, will sustain meaningful weight loss beyond 1 year. As you rightly note, that the majority of patients will regain the majority of the weight within a year, if not actually gain weight further. So it is a huge challenge, despite all of the non-pharmacological means we have. And again, some of it comes down to our ability to select out those who are more likely to then benefit from pharmacological therapy. Again, recognizing the then need to consider that lifelong, versus more significant interventions. So consider gastric balloon versus bariatric metabolic surgery, so Roux-en-Y and sleeve gastrectomy, which is obviously an extreme option. And again, these are resource intense interventions, and a lot of patients are not particularly keen for them. So I agree. I think it's a real problem, and part of the challenge, I suppose, is probably stopping people gaining weight in the first place. I think once you're in that cycle and this idea that you get an automatic metabolic reset point, it becomes very hard to shift that needle. And I think that's probably universal, despite most of our the kind of optimization of our non-pharmacological interventions.
Yeah, I think that's pretty much everywhere has we face
Yeah.
this problem. But I think one thing I'm very surprised by is the awareness of fatty liver in the UK. I think it's much more pronounced compared to Asian countries in general. I think would you agree that it becomes more of like a people think of it more like a diabetes, something that's very common, or is it something
Yeah,
that's more obscure?
I think our clinicians are more aware of it, probably because we keep harassing them. But I think it's important, and again, having an automated liver function testing thing that pings back to a GP and says your patient has MASLD, patient has NAFLD with advanced fibrosis, just reinforce, they need to see us in clinic. I mean, that's what the alert tells them. And I think that's quite a powerful thing, is that for years people just thought this is a bystander illness. I think our patient awareness is probably very low. We're just conducting a Scotland-wide survey of 1,200 patients across different metabolic spheres and clinics. And when we suspect a bit similar to Zubair's and others, studies that we suspect less than 10% of people will have been told that they have MASLD or that it exists or any variant of fatty liver disease, NAFLD, MASLD. We suspect their awareness will be relatively low, but we'll hopefully get the results of that in the next couple of months. But again, that will help inform again public health policy and education and awareness, because I think that's part of the hidden the agenda that we need to really highlight to patients and again to other clinicians, and particularly with treatments on the horizon. Suddenly, I think that this will probably be force a paradigm shift in the field.
Okay. Okay. So thanks so much, Doctor, for sharing today. I think that brings us to the end of the podcast. So thank you for the time for participating in this, and I hope to see you again soon.
Fantastic. Thank you so much for having me anytime.